Please.
My lady, I can see you both now. Thank you. My lady, the next witness is Vaughan Gething.
Mr. Gething, can you hear me?
I can.
If you'd like to repeat the words after me. I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Good morning, Mr. Gething. Welcome back.
Good morning, my lady. Good to see you again.
Thank you for attending the inquiry today, Mr. Gething, and good morning. I believe this is the 5th time you have provided evidence to this inquiry. Thank you for providing your witness statement to this module dated the 3rd of April 2025. My questions today will focus specifically on the response in relation to the adult social care sector. By way of brief background, and you give further detail in your written statement, you have been a member of the Senedd since May 2011. You were first appointed as a Deputy Minister in June 2013, and during the pandemic you held 2 ministerial roles. Firstly, you were the Minister for Health and Social Services, a position you had held prior to the pandemic and held until May 2021, and you were then appointed as Minister for the Economy. Is that correct?
That is correct.
You explain at paragraph 11 of your statement that your responsibilities in relation to social care were fundamentally different to your responsibilities in relation to health. The Welsh ministers are responsible for the promotion and provision of a comprehensive health service in Wales, which includes the provision of hospitals and other services or facilities as required for the diagnosis and treatment of illness. There is no equivalent statutory duty in relation to social care, although Welsh ministers do have a range of powers and functions under the 2014 Act and are therefore responsible for the decisions made with regards to those functions. And you explain that statutory responsibilities are vested in local authorities and that social services and social care are funded in a different way to health services. Is that all accurate?
That is correct.
Mr. Hancock, when he gave evidence to the inquiry in this module, said that there was a hodgepodge of accountability that meant that the levers we had at the centre were weak in respect of social care. Is that something you felt to be the case in Wales?
I wouldn't put it in quite those pejorative terms. The accountability lines are different. The NHS is essentially line managed by the Welsh Government. Social care is a function of local authority, so the levers are different. The sector, though, is organised in a very different way. And as I said in my statement, and others I'm sure have as well, there are challenges about the way that the sector is organised, about directly provided care, and indeed the range of private providers that are commissioned by either local government or the NHS.
Can you provide an overview of any difficulties caused in respect of the organisation of the sector and as far as the response to the pandemic, please?
Yes, so I think I covered this in my statement. There are at the time about 1,200 care homes in Wales of a variety of sizes. Most of those are privately run. You have quite small care homes in some instances, essentially converted large houses, and you have purpose-built care homes that are much larger. So there's a variety of providers. There are some fairly significant groups of provision and very individual care homes as well. Some of those are residents who directly pay for their own care. Others have commissioned care, largely by local authorities. And when there's nursing care available, sometimes it is the NHS that is commissioning that care as well. So the sector is in a difficult position compared to the NHS, where you have one stream of accountability going through the service. And of course, it is not one that the Welsh Government directly line manages either. We do have overview responsibilities, as I set out in my statement. The sector is also relatively poorly funded, and we have challenges around staff, age of staff, some post-Brexit challenges about the numbers of staff, and I'm trying to raise the the esteem in which the service is held, and regular challenges about pay as well. It's a relatively low-paid sector of the economy.
Mr Gathing, some have described the social care sector as the Cinderella service of public services, including the Adult Directors of Social Services Cymru. Is that a statement you would agree with?
I recognise where that comes from, because it's relatively low paid, but actually it's hugely important. It employs very large numbers of people. Most of those are women. And I think the public don't really appreciate the residential social care sector and the domiciliary care sector because it's not as visible as the health service. And I think when people interact with that sector, they're then surprised that it doesn't have more to it. And, you know, it's a sector that I'm familiar with myself, not as a minister, but, you know, I've got family who interact with the sector as well.
Two more general questions, please. Firstly, in your view, did pre-pandemic plans and indeed the response over the pandemic in Wales in any way overlook the domiciliary care sector?
I wouldn't want to say yes with confidence to that. You see, the domiciliary care sector, where care is provided in someone's private home as opposed to a care home, although for some residents their care home is their home. I think there's always a challenge about the variety of the tasks that the domiciliary care sector undertake, from relatively intimate ones to lower level tasks as well. But actually, from a funding point of view, actually the provision of that care from a local authority commission service, the need level has gone up, not down. But there's always a challenge, and I'm sure it's one of the things we'll look at in terms of lessons learned about factoring in both care home provision as well as domiciliary care in someone's own private home as well.
And can I ask, please, the same question in respect of the response with unpaid carers? So did pre-pandemic plans and the response over the pandemic in any way overlook the provision of unpaid care?
I think the scale of unpaid carers was something that was very apparent in our minds in a whole range of areas. But when it came to pandemic planning, I think it is, again, one of the lessons to learn about how do you support unpaid carers. The voice of unpaid carers was, I think, pretty significant throughout the pandemic. In all of our weekly press conferences, there were representatives of unpaid carers asking questions. So it was regularly a feature in the minds of ministers who were going through it. But I do think for the future, it's an area to focus on again, to think about how do you properly support the very large numbers of unpaid carers. And, you know, to be blunt, there are plenty of ministers who are acting as unpaid carers in roles within their own families. Not of the range of significance that you might hear described through the evidence, but it's a sector that I think does bear greater attention in the future.
Mr Gathing, can I please now move on to hospital discharge in March 2020? Now, you have given evidence about this topic, including the emerging evidence on asymptomatic transmission in other modules of this inquiry. And the inquiry will, of course, consider all the evidence you've provided. But I do have a few questions arising, please. In your Module 2B statement at paragraph 493, you explained that at the time of your announcement of the framework of actions on the 13th of March 2020, the testing of asymptomatic patients being discharged from hospital was not discussed with you. You say in the same statement at paragraph 171 that there was a paper from SAGE on the 3rd of March 2020 which said that asymptomatic transmission could not be ruled out. In Module 7 this year, on the 20th of May, you were asked if you were aware of the possibility of asymptomatic transmission by the time of Mr Drakeford's statement to the Senedd on the 24th of March 2020, in which he said, while you are asymptomatic, you could be passing the virus on to somebody who is much more vulnerable, and that fed into the decision to stay at home. And you said it was a possibility. Even if it was not specifically discussed with you in respect of the framework on the 13th of March, would you agree by that date that you were aware of the possibility of asymptomatic transmission and that it could not be ruled out?
I'm not sure that by the 13th of March I could say that I was aware of the possibility of asymptomatic transmission. We discussed transmission, and the clear evidence and advice was symptomatic people were the risk. But that doesn't mean that it couldn't be ruled out. So I think that's a fair answer to the question you put, that I certainly wasn't aware of asymptomatic transmission being a real risk, but that doesn't mean that I could say it had been positively ruled out. And that's the level of uncertainty upon which decisions have to be made.
I'm grateful, Mr. Gathing. So you accept it couldn't be ruled out. That's a fair way of putting it.
I think that's a fair way of putting it.
When you made the announcement on the 13th of March, had you queried or challenged the advice you were receiving, given the implications that the possibility, or in your words, the fact that asymptomatic transmission could not be ruled out, so the impact that may have on the adult social care sector in light of expedited discharge?
I think the challenge is that in agreeing that framework of actions on the 13th of March, the clarity of the advice is around symptomatic people, and they are a definite vector, potential vector about being infectious. It's also because by this point, the really harrowing scenes in northern Italy have played out, and the risk isn't neatly packaged up in one part of society. As we know that COVID is spreading through the UK, largely from an introduction from Europe from February half-term visits, there's risk in hospitals, there's risk in the community, and there's risk in every other sector outside hospitals as well. And we know, I'm afraid, we're pretty certain, that if people who don't need to be in a hospital anymore are still in that hospital, then not only is there a risk in normal times of them coming to harm, that's what happens with delayed discharges, but actually if we're having more people with COVID who need an acute hospital bed, then we will see harm throughout our sector, and that is disproportionately harm that affects older people. It's the core business of NHS hospitals is older people at any one point in time in terms of people in a bed. So you're dealing with risk right across the spectrum. And it's about where and how you balance that risk, knowing that the majority of that risk is going to come into your hospital in the coming days ahead.
Mr. Gathing, do you agree from the 13th of March 2020, at the very least, there should have been a policy for all new admissions to care homes who had not been tested and were going to be discharged into a care home, that they should have been isolated upon admission?
Well, that wasn't the evidence and the advice we had at the time. And I guess it depends on whether you're asking me based on what I knew at the time, the advice I received at the time, compared to what I know now, because they're two different points, aren't they? The advice and the evidence at the time was that this was the right way to strike a balance. And there was no advice that came to me saying you should test everyone who was leaving a hospital. That advice was never provided to me at this point in time. And I think it's very hard to second guess all that and say at the time, should you have known? Well, actually, I didn't. Looking back, though, of course, in hindsight, you can see that actually you could have reduced risk if you had been able to test on discharge. And that would also rely on not just capacity, but the speed of turnaround from testing as well. Because if you test someone and you get the results back 36 hours later, there's no guarantee that you've eliminated the risk. So at the time, that wasn't the advice. It wasn't in front of me. So I don't think it would be real to say that I could and should have gone behind and around that advice. But in hindsight, there's plainly a different range of considerations that we could have made at the time.
And therefore, looking forwards, which is part of the purpose of this inquiry, in these circumstances, do you agree that it would be sensible to have that precaution in place in the future?
Yes, but there's a but, and it's a pretty significant but. It does depend on whether you've got the tests available, the speed of the tests available, and you still have to look at the balance of harm and risk. Because as I say, if you know you're going to have lots of people coming into a hospital who need care and will suffer and potentially die without that care, you've got to balance that against what you do across the whole sector. And it also depends on the nature and the state of the scientific evidence and advice at the time, because I can't predict for you now what the next pandemic will be. It could be something, because coronavirus up to this point weren't thought to be transmissible. unless people were symptomatic. It might not be a coronavirus in the future. If we were dealing with a transmissible disease where asymptomatic transmission was a possibility, and you have the ability to test and the test rapidly, then yes, it's something you should do at the start. But whoever the decision maker is will need to deal with the level of certainty and uncertainty they have in the face of the next pandemic. But in hindsight, with this pandemic, if we'd been able to test on discharge from hospital, we could have eliminated risk and, as importantly, I think, maintain confidence within the residential care sector as well.
Thank you. I think we may be conflating two separate issues. At the moment, in respect of the fact that there was not enough testing capacity in your evidence at that time, do you agree that in those circumstances where there is limited testing capacity, it would be sensible to isolate people if there isn't an opportunity to test them?
If there isn't an opportunity to test, then using isolation is part of that, yes. And then you're into making sure you have adequate PPE for people, and you need step-down facilities for people to go into. And more modern care homes do have isolation facilities. If you're looking at other isolations, you need to identify where they are and how you protect a resident population in any closed setting. So there are different factors, aren't they? If you have enough tests, there's one thing you can do, particularly the speed of the tests. If you don't have enough tests, then you've got to consider isolation as one of the additional measures.
Thank you. And one of the steps taken in Wales from the 29th of April was step up, step down guidance. Is that something you think should have been brought in earlier than the 29th of April?
So I think we've made a concession on this, haven't we, in terms of the fact that once a decision has been made, I think on the 15th, 16th of April, and is then communicated in a letter to care homes
Yes.
about what we're going to be doing. I think that's the 22nd of April that letter goes out, but the guidance still, it's another week. It is also still about making sure you've got enough step up and step down provision and where that provision is actually located, because some care homes have more of a challenge with doing that, and then in some parts of the country you may be able to use other NHS facilities as step up and step down.
Would you agree that this is something that needs to be thought about in planning for a future pandemic, the availability of those settings for care homes that may not be able to offer isolation?
Yes, and it also goes in with your means and ability to do so, how quickly you can do it. So, for example, when we created a field hospital network in Wales, it took time to do that. You've got to identify the areas, you've got to get them staffed and ready. But that then essentially gives you more flexibility to do this with the numbers you potentially need as well. But part of our challenge is that we don't build into the way we run our health and social care system lots of additional capacity that is unused. So, care homes need 90% occupancy plus to be financially viable at present. So there isn't lots of additional capacity built in to flex around that. If you're facing a pandemic, though, and you recognise you need more, it is entirely reasonable to plan for how could you flex up and provide more step up and step down capacity if you need to have someone outside of an acute hospital setting to care for people before they return to either their own private home on a normal street or a flat, or indeed, if their home is a care home, when and how they return there.
Can we now please, and I think you have just touched upon it, the decision about testing and the capacity. And in Module 7, you said not testing patients on discharge as a matter of routine was in line with advice from Public Health Wales and SAGE on prioritising tests for best effect. This was based on understanding of transmission at the time. And I think your evidence to us today is that that was the evidence you were receiving at the time. Is that right?
That's correct.
Now, in Module 2B, when discussing asymptomatic transmission more generally, you gave evidence that you think actually if you have greater testing capacity, you can do a great deal more. And then just finally, one more piece of background before my next question. In a press conference in June 2020, you said that testing capacity had no bearing on the original decision not to test people without symptoms going into care homes. and you said if we'd had treble the amount of testing capacity at any point in time, then that was still the evidence and advice we had on how to make use of all of our resources. We did not get advice that said you really should do this, but can't because you don't have capacity. To make a link between testing capacity and the choice we made is not borne out by the facts. And so my question is, if in fact you did have treble the testing capacity or more testing capacity, do you think that could have impacted on the decisions that were made? Or do you stand by those comments made in June 2020?
No, I think it's still the case that that was the evidence and advice at the time. It would be wrong for me to try to recast my evidence based on the advice we had at the time. Separate to that, it is of course possible that if you have lots more testing capacity, how you use it and how you prioritise that can change and give you more flexibility. Because that testing capacity isn't just for COVID. I think we've been through this before in my previous evidence. That testing, that lab capacity is also testing for a range of other conditions a health service needs to be able to provide for, including during the pandemic. But if you have more capacity, then the way that you prioritise the use of those resources based on the advice can change as well. And so, it isn't just my evidence on the state and nod of asymptomatic transmission. I know Chris Witt in his Module 2B evidence runs through the changing understanding and knowledge about transmission. So at the time, that was the advice, and that was the choice that I made based on that advice. But if we had more capacity, then we would have run through our list of priorities about how to use that capacity in a way in which we could have done.
So perhaps your evidence today is not quite as strong as the statement made in June 2020, that you definitely wouldn't have done it. You might have done it. Is that fair?
But the statement I made in June 2020 was reiterating that that was the evidence and advice I had at the time. And I didn't have alternative advice that says use this in a different way. And actually trying to forecast what you might do for different resources is actually really hard. And I think you're getting into a really hypothetical position there. When you're giving and delivering that press statement, particularly with the challenges the country is facing, then it's very hard to engage in hypotheticals, because part of your job is to both explain choices and provide a level of reassurance about the evidence base you have to work with. And that's what I was doing.
Professor Cole of Public Health Wales told the inquiry earlier in this module that Public Health Wales did not have access to the numbers of hospital discharges to care homes. Given that they were responsible for advising on testing, do you agree that in the future that's important information that they should have access to?
I think it's important that Public Health Wales are properly part of the way in which we deliver a response to the pandemic in all aspects. That's hospital discharge and a range of other things as well. In terms of the initial period of response, I think it is fair to say that we needed to draw our system together in a way that we hadn't had to before, because Public Health Wales has led on localised outbreaks, but they couldn't lead in that same way on this national pandemic. So understanding that data would be helpful for everyone, but of course on a local level where we had incident management teams, Public Health Wales are engaged in that as well. And it's really about what data we're talking about and when it needs to be provided. And of course Public Health Wales are, if you like, leading the way on the guidance for care homes at the time. In fact, it's Public Health Wales' guidance that is essentially published and delivered for care homes at this point in time.
So specifically then, the numbers of hospital discharges to care homes, you would agree that that would be useful for them to have in the future?
I can say it would be useful, but not just in itself, because it is both the number of discharges, our understanding of the science on discharge in itself, with or without a test, our ability to do that, what the pandemic is in front of us, and how that affects the ability of those care homes to handle those patients. Because there is a point of reasonable contest, and can every care home manage every patient? And in normal times, they can't. In the pandemic, that's also a factor as well. I know that came up in conversation with a range of stakeholders. So it isn't just about providing more data, it's data for a purpose to try to give you a more joined up answer. And I think my understanding is that's essentially what Professor Core was saying, and I don't take any dispute with that at all.
Just a few more short questions, please, on the 13th of March before we move on. Mr. Gethin, you've frozen on my screen. Thank you, you're back. At paragraph 95 of your Module 6 statement, you say that in the briefing you received on the 13th of March 2020, it said the National Pandemic Flu Plan provided a framework of actions and that every health organisation had an excellent plan in which they had been in the process of reviewing in the preceding month. Did you ask whether there were any similar plans in respect of the care sector about how they would cope with the implications of such a framework?
My understanding is that for the pandemic plan, that care homes had plans around what to do with a flu pandemic and the intake for that. And of course, we're in normal times, in the middle of March, you're at the end of the normal flu season. And, sadly, flu takes the lives of people every year, including in the residential care sector. And when you have infectious conditions, whether it's flu or DNV in a care home, part of the challenge is there are supposed to be existing isolation facilities. I think the challenge here was the scale of those isolation facilities and the adequacy of them in each care home, because this is a bigger and even more important consideration. But it's the point about having the plan about the way that the local NHS and social care providers are supposed to be able to work together to implement those plans for a pandemic.
And you've said it's your understanding that there were plans. Were they shared with you, or did you ask to review them before making that announcement?
No, it would have been unreasonable for me to have said that I want to review 7 different health board area plans or potentially 22 local authority plans.
Do you know if anybody reviewed them?
Health boards were due to review their plans. They're supposed to have a framework of actions to review and amend. They've been asked to review and amend those in the preceding month. So the review of those plans should already have taken place. And actually, by the middle of March, the speed of decision-making and the progress of the pandemic is such that your normal time frame in government for reviewing things rapidly, if you do something rapidly within a month, that's pretty extraordinary. Actually, a month is a very long time in the pandemic. And the speed of decision-making required means you have to make choices. So yes, it was my understanding, and that's what this section of this paragraph of my statement is trying to get over, that even the pandemic flu plan, people have been asked to review those in the preceding month and amend those within the preceding month. So at this point, there should have been content about what to do. The challenge is the scale of what's required and the speed of what's required.
Just finally then, please, on the framework of actions. Looking back, do you think there was a strong enough voice, or indeed any voice in those discussions, representing the care sector as opposed to the hospital sector?
But the way the government works is our Health and Social Services Director is made up of health and social care. So it's not simply an NHS department that has social care tagged on. And it is about how you deal with risk for the country, not just one sector of it as well. It's the point I made earlier about the risk in someone's home, the risk for someone in an ambulance at the front door of a hospital, in a hospital, and then when they need to leave as well, and the risk when people return to wherever their home is, including a care home itself. And I still think the framework of actions was based on our best understanding of knowledge at the time. And there are definitely strong social care voices within the government when all of these conversations are taking place. I know you're going to hear from Mr. Heaney later today.
Mr. Grigg, I was about to ask who was the strong voice in those discussions. Would that have been Mr. Heaney?
Yeah, he was the deputy director, so the number 2 in the department. And, we have a team of people within the department. There are also conversations with Care Inspectorate Wales as well. So there's always a demand for more people to be involved in conversations. And in normal times, you'd have gone out and talked to local authorities and the Care Providers Forum as well. The luxury of the time that would take isn't available to us as we're going through this.
Can I move on now, please, to the 8th of April? And can we please have on screen INQ 3055178 at page 89? And this is an extract from Albert Heaney's statement to this module. And at paragraph 308, it says, and this is in respect of the 8th of April, it was clear that if discharges were made, hospitals would not be able to function effectively, which would inevitably lead to increased deaths. In the absence of advice to the contrary from health experts and evidence regarding asymptomatic transmission, while testing of all patients would have been preferred, without sufficient testing capacity, it was not possible. Do you agree with what Mr. Heaney says there, that at this date, testing of all patients would have been preferred?
In hindsight, yes, but this is I think Mr. Heaney is describing a conversation between officials, because certainly on the 8th of April, no advice comes to me that testing of all patients upon discharge would be preferred, but there is not the capacity to do so. But you expect your officials to have robust and honest discussions, and I think the point is that if discharge are not made, there will be increased deaths. And
is there a possibility
there's an awful certainty about that. In addition to not just deaths in hospital, but you'll find deaths for people who don't make it into an NHS bed.
Is there a possibility then that there was a conversation between officials about this, and that's something we can clarify with Mr. Heaney?
It's entirely possible. Ministers don't get to see every conversation officials have, and actually you expect officials to have robust conversations and then to provide a view for ministers that either sets out areas of disagreement or areas of agreement for ministers to make decisions on. But I couldn't tell you the detail of that part of Mr. Heaney's statement. I'm sure you'll take it up with him this afternoon.
That document can come down, thank you. On the 10th of April, you asked that a note be issued by the Chief Medical Officer for Wales to Care4 Wales to provide clarity and reassurance around the testing of patients being discharged from hospitals into care homes. Why did you feel that that was something that was necessary?
We'd had a letter, I think, on the 8th of April. Care4 Wales had written to the First Minister, copied to myself and Julie Morgan, the Deputy Minister responsible for social care. And they had expressed concern about the position. And the concern isn't irrational. People are reasonably and rationally worried about what is happening in every aspect of their life. So Care4 Wales, as the largest organisation of private sector providers, are making representations directly saying we are concerned about this. So my request to the Chief Medical Officer is to provide reassurance about why the decisions are being made as they are, the underlying public health advice that goes into that advice, and to try to give as much reassurance as possible. It's both about the position on the state of knowledge at the time, but it's also about you need confidence for your system to function effectively. Because if the system breaks down, you can guarantee that harm will be caused to both staff and potential patients or residents. I think social care refers to them as clients.
In an email from your private secretary on the same date, so the 10th of April, to Sir Frank Atherton and others, it was recorded that the ministers would like to receive daily or every other day updates from Data Wales on the testing numbers as a whole and broken down into health and social care. They realise there may be a confidentiality concern, but it should be easy to provide this information to both the Minister and Deputy Minister on a daily basis. So by that date, on the 10th of April, do you consider that there was a gap in the data that you were receiving about testing figures?
My recollection of this is this relates to the testing of staff as much as anyone else. So we had looked to create a system for frontline staff to be prioritised with testing. And one of the complaints at the time was that I think it was 15 per local authority was relatively low. In fact, we weren't seeing a take-up of all 15 of those tests. So I do recall, because I was asked about this in one of the regular press conferences about what was happening. having agreed to create a system to do that, because of the understandable priority for social care staff in particular, to not see that taken up was frustrating. So it's part of understanding, is this being taken up, or is this a provision that is more than is required? And I think there were complaints about how easy the system was to use, but I expected the system to be used and maximised, because that would then mean that if staff were concerned, they could isolate, and if they got a negative test, they could return to the workplace with some confidence. If the system isn't being used, then we need to understand why. So there's a bit of push and pull in doing this as well. And that's part of the overall, and you've seen, I think, my messages around this through April, around, are we making best use of the capacity we have? And is there a reluctance to use that capacity for reasons that aren't coming through to me? Because PPE is actually a bigger concern at this point in time in terms of things across my desk. But of course, I'm aware of the challenges around testing and the need to increase it, because it's also a very difficult time in terms of our ability or inability to increase our testing resources more generally.
And we'll come on to that in a little bit more detail, but just specifically in respect of the lack of data on testing, do you think that that information should have been provided to you earlier than the 10th of April if you're querying it at this point? Would it have been helpful?
It would always be helpful to have more data in front of you that is useful. And it was because, and I recall there being a challenge around, we're not getting enough tests. I thought we'd resolve that by having a system to have prioritised tests. And actually the feedback was they aren't all being taken up. So I'd ask for the data so I could understand and see in front of me, are these tests being used? Are they being maximised out? Or is it a case that we're not getting people to use the system that we have to its best effect?
Now, at paragraph 109, you explain that following a ministerial meeting on the 15th of April 2020, Public Health Wales was informed that the Chief Medical Officer for Wales and the Deputy Director for General Health and Social Services wanted a revised approach to testing to be put in place as soon as possible to include testing on hospital discharge. You explain you sent an email the next day to express your general concern that at that point I did not have clarity about why we had testing commitments that we could not meet. And you say these issues included testing of care home residents on release from hospital. Putting aside the capacity concerns for the moment, but just dealing with the decision on the 15th of April, were you a party to the decision to test all patients on discharge, or was that taken by officials?
No, so paragraph 108 of my statement goes through the discussion that took place between the First Minister and a range of ministers, definitely myself and the Deputy Minister for Social Care. It's also the day that the UK government announced their plan for social care, and they say that they will test all patients before discharge. Now, we didn't receive advance notice of that, or the basis upon which that was done. So you have these twin challenges of, is the evidence base changing around transmission and the ability to test? And of course, the evidence base around asymptomatic transmission is changing all the time through April. So I'll try and speak slower. I regularly get warnings about it. As well as the evidence base changing, England then have a significant intervention where they say we are going to do this, and it's a surprise to us. And by this point, particularly following the letter from Care Forum Wales and representations from local authority leaders, we're concerned that regardless of the evidence on testing, we may not be able to maintain the confidence needed for the system to keep on working. If local authorities or significant care home providers say, look, we don't care what you say about the evidence, we're just not doing this, we're too worried, then actually that is the point at which your system is breaking down. You can guarantee harm will come. Harm to those people who need not to be in a hospital bed, because hospital in normal times is the right place to be when you're really ill, and it's very quickly the wrong place to be. You can get deconditioned and have harm caused to you when you don't need to be there. In the pandemic, where you're confident, in April, remember, we're having significant numbers of people testing positive, more people coming into hospital needing the provision that only an acute bed in the NHS can provide. If your system breaks down at the back door, your normal risk and delayed discharges are even more significant. And that's when you potentially get undignified care, but also the risk of an increased amount of mortality that is potentially avoidable. So maintaining confidence in the system is hugely important.
Can I just pause you there, Mr. Gathing? I understand that's the reasons why the decision was taken, but it doesn't seem from the note of the ministerial meeting on the 15th of April that the decision was actually taken in that meeting. So can you help us with who actually took the decision and whether you were involved in the taking of the decision on that day?
No, I think that meeting gives a directive for officials to go and look at changing the policy. So in 109, when it says Public Health Wales are told that the CMO and the Deputy Director General want a revised approach, that comes from the ministerial meeting. And I'm pretty sure that Frank Atherton certainly is involved in that meeting. I can't recollect, I haven't seen the notes, but I'd be surprised if Albert Heaney wasn't also dialed into the meeting as well. But the direct approach comes from the CMO and the Deputy Director, the senior officer in the government on social care, to Public Health Wales, saying we need to revise our approach.
Would it be fair to say it was a ministerial decision then?
Yes, I think it is. And that's, if you go back to the concession the Welsh Government's made, it recognises ministers made a decision and the guidance wasn't provided until 2 weeks later, even though a letter went out a week later to care homes saying this is what's going to happen.
Can we explore that then? Sorry, Mr.
Yes.
Gathing. Can we explore that then, please? Yes, as you say, the decision was taken on the 15th of April and the subsequent guidance was not published until the 29th of April. Do you accept, along with the Welsh Government, that that was a delay that simply shouldn't have happened?
Yeah, it's part of the concession that I don't attempt to walk away from. From the decision to the guidance going out, I think it has to be accepted that the guidance could have been provided earlier. And of course, we wrote to care homes, wrote to the sector on the 22nd of April. That's not the same as having the guidance available. So the practice started earlier than the guidance. But for consistency and successful successfully implementing the decision, having the guidance earlier would obviously have helped that. And I think it's perfectly right and proper the concession's been made.
Public Health Wales told the inquiry that there would have been capacity to implement that specific decision, so testing all patients on discharge from the 15th of April. Is that something you're aware of, or can you disagree with that in any way?
No, I wasn't aware that was the view of Public Health Wales.
And so in that respect, why did the Welsh Government need to wait for guidance? Why could it not have implemented the change from the 15th of April, given the significance?
So once ministers make the decision, there's then the conversation with Public Health Wales about being able to do this. And again, I know from my statement refers to the chronology in Albert Heaney's statement. The letter that then went out on the 22nd of April, I understand Gillian Baranski's confirmed this in her evidence last week, that actually they were starting to see that there were tests being undertaken from a week later, and the challenges about how quickly that can be done and communicated. If we'd simply announced on the 15th of April this is going to happen, you're into the way in which if you announce a decision and implement it afterwards, you potentially have a more chaotic approach to it. And we want the system to be ready and to get on with delivering it. The concession is that actually having made the decision, it should have been delivered earlier. And so I can't give you an exact day about when that would have happened. And I can't tell you why Public Health Wales, who don't actually operationalise all these decisions, will be able to say that could have been dealt with on a certain point in time. But I accept that it could have been done earlier following the ministerial decision, and that's consistent with the concession that's been made.
Grateful, Mr. Gathing. You've touched on this before, and you say that there wasn't the sharing of information you'd have expected between the Department of Health and others, and you've touched on the position in England on the 15th of April. But we're aware that there was earlier testing of all patients on discharge in both Scotland and Northern Ireland. Do you say that this did in fact cause a particular delay in Wales specifically?
Sorry, I don't understand the question.
You explain that one of the reasons why there was difficulty is that because the Welsh Government wasn't aware that the English Government was going to change its position, or that the UK Government was going to change its position. And your quote is, "It's one of the areas where there wasn't the sharing of information you'd have expected between Department of Health and others. But if the same information had been shared with us instead of being announced, then I think we could have been in a different position." And so my question is, did the delay in the Department of Health passing on that information actually lead to any delay in Wales? Because both Scotland and Northern Ireland were able to implement the policy quicker than Wales.
It's part about the evidential base about the science and the public health advice about whether this is the right thing to do. And it's also then about confidence in your system as well, to maintain that confidence. If England were intending to do this, there wasn't a sharing of scientific or public health advice, and this is the justification for it. And I think we've been through that before. It's part of conversation between health ministers as well. But if you're trying to hold up a position that is based on the evidence, and then your neighbour with a porous border goes the other way, then actually your ability to maintain confidence is undermined. And you can't be in a finger in the dike position because, as I said, the risk, and it's a real risk that is on my mind throughout this particular part of the crisis, is if we can't get people moving in and around the health and care system as they need to, then we could have a Northern Italy situation on our hands, and we could have lots of people dying who don't need to. And so all of those things are in my mind. And even if it had been a conversation between officials before they'd announced it, the day before, even the morning when they were announcing it, we would have been in a better position. The earlier the information is shared, the earlier we can take that into account. And of course, those decisions do affect the choices we make for more than one reason, as I've set out.
So would it be fair to say then that your evidence is it put Wales perhaps on the back foot, but it's not the reason why there was then the 14-day delay in Wales? Is that a fair summary?
I think that is fair. I wouldn't try to say the decision in England is the reason for the 14-day delay from the ministers making a decision to the guidance going out. That would certainly not be fair. But it is fair to say that, of course, it put us on the back foot, and we could have been in a better position if we'd had earlier notice.
Reflecting then on the discharge policy, please, and at paragraph 120, you refer to the 6th of May 2020 SAGE consensus statement on the association between the discharge of patients from hospitals and COVID-19 in care homes. And you say COVID-19 in care homes was not solely imported from the hospital. Do you therefore accept that the discharge of patients to care homes without a test did lead to at least some cases of COVID-19 being introduced into care homes?
Yeah, I think it would be impossible for me to say otherwise, because what we now know and have much more confidence on in asymptomatic transmission is it's entirely possible that that was a factor in COVID getting into some care homes, even if it wasn't the dominant factor. And this is about understanding all of your different risks and how you try and address those, both at the time and looking back, which is why, from your earlier questions, I'm making the point around if you can provide asymptomatic testing to help with hospital discharge, there are good reasons to do so, particularly given our experience of this pandemic.
Do you agree that, I think you've just acknowledged this, the extent of how many cases were imported through this route is difficult to determine, particularly in light of the lack of testing generally in March and April? Is that fair?
I think it is difficult to determine. As part of the SAGE consensus statement you refer to in paragraph 120, Public Health Wales did a large study looking at 3,000 discharges, and they come to the same conclusion that the SAGE consensus statement does. That you can't rule out it being a factor, but there are a range of hospital homes that have hospital discharges that don't have an outbreak. It's not the sole factor, it's not the dominant factor, but I think you'd have to accept that it is a factor in how COVID got into some care homes in Wales. And I certainly don't want to try and avoid that conclusion, because I think that has to be right, doesn't it? It would be illogical to think otherwise.
The inquiry has heard evidence about another route of transmission into care homes, which was through the movement of staff, particularly agency staff, those on 0 hours contracts. Mr Hancock, when he gave evidence to the inquiry, discussed the significance of staff movement and said you could easily rejig the employment arrangements to reduce staff movement. Do you think the reduction of staff movement between care homes was something that was desirable in Wales? And reflecting back on your experiences over the pandemic, are there any practical ways something like that could be achieved?
Well, I think this is a real problem and a real factor. People going into care homes are what changed the nature of COVID in care homes. And, staff are one of the factors. That's not a criticism of staff who made extraordinary sacrifices. But if you've got people working between 3 care homes, then it's much more likely to be a factor. We did go through this between health ministers and in calls, and part of the challenge, I think, is I don't think it is as simple as just rejigging the employment being something that's easy to do. Actually, what you need to do is you need to do something about sick pay, and you need to do something about terms and conditions within the sector more generally. If you work 3 jobs in 3 different care homes, it almost certainly isn't because you love working in 3 different settings. It's about how you make your wages up to be able to feed your family and put a roof over your head. If the pay in care homes doesn't mean you can do that in a single employment, people will work more than 1 job. That's not, I think, contestable. When you don't have sick pay, then actually part of your problem is that you're giving people a perverse incentive not to isolate, not to take themselves out. But it's I go through this in my statement in this module and in module 2B. It's a rational thing for a person to do, to consider, do I go into work and recognise that I won't be able to feed my family at the end of the week? Or do I not go into work and because I'm worried about what might happen if I go into work, I'm not feeling 100%. If you don't have reasonable levels of sick pay, then you understand why people make different choices. And it was part of our frustration in conversation with the UK, and we couldn't do something to actually deliver sick pay through the sector. The challenge on wages is part of the longer term reform I think the sector needs.
Perhaps while we're on this topic then, if we can move to funding, you confirm in your statement that as early as March you had received correspondence from trade unions drawing your attention to the fact that those who worked in social care who were required to self-isolate or who fell ill would only receive statutory sick pay and so would not be able to afford to take time off work. And I think this is something you say had your sympathies from early on in the pandemic. Is that right?
That's correct.
You outline in your statement, and the inquiry's heard evidence, that the UK government announced the Infection and Control Fund in May 2020, and part of the purpose of the fund was to ensure that staff who were isolating received their normal wages while doing so. And in fact, in Wales, it was recommended in the COVID-19 Black, Asian and Minority Ethnic Socio-Economic Subgroups report that thought should be given to funding, particularly for those who needed to isolate in the social care sector. However, as you've told the inquiry in your evidence, the statutory sick pay enhancement scheme in Wales did not come in until November 2020, and this was later than all other parts of the UK had addressed this issue. Now, I appreciate you cover this in your statement, in your written evidence, but can you please explain why it was that the scheme came in later in Wales, please?
Because of the uncertainty around what happens with Barnett consequentials. So an announcement is made in England. We're told roughly there'll be a consequential, but those consequentials can change later in the year. So you don't have all the financial certainty to make choices. That is a real factor. It's also, I think, linked to the suggestion about an additional payment for social care workers as well. Now, the level of certainty that we needed to be able to make the choice on sick pay wasn't there until later in the year. And I go through my statement about the range of funding pressures that were available. would have liked us to have been in a position to have confirmed the position on sick pay earlier, but there was a level of real caution and concern that our budgets would be changed later in the year, and we would find ourselves not able to meet the commitments that we wanted to make. So it's a real point of unhappiness and frustration that we weren't able to do this earlier. We had greater certainty on funding and that the funding wouldn't be clawed back. We could have acted earlier.
Mr. Gethin, I'm sorry to interrupt, but Ms. Paisley's question was carefully phrased. The statutory sick pay scheme in Wales didn't come in until November 2020, later than the other parts of the United Kingdom, including the other two devolved nations, all of whom are subject to the same kind of challenges you have just described. So could you please now try to address why the Welsh scheme came in later than Northern Ireland or Scotland and England?
Yeah, there's still a level of caution. It's about how quickly we're able to move with the work that's being done in Wales. I think it is fair to say that I would have liked that scheme to come in much earlier, and the conversations we're having with the whole sector. So I think it's reasonable to say that I would definitely have wanted that scheme to have come in earlier than it did. We couldn't do it immediately when the announcement was made in England, and that caution around trying to understand where is the realistic level of possibility this money could be clawed back, and when do we have enough certainty to go ahead and deliver the scheme as well.
Can I ask, were there conversations with Scottish and Northern Ireland ministers, or indeed between officials, to ask how it was that Scotland and Northern Ireland had found a way through these problems? And if there wasn't, would that have helped?
I think our officials did have conversations with counterparts in Scotland in particular, but the officials working on that, with having those conversations with the officials working on the scheme in Wales as well, and having conversations with stakeholders in the sector.
Given the significance of this matter, in the event of a future pandemic, how could such a scheme be introduced quicker?
It's one of the points that I've made in, I think, Module 2 as well as this one, that actually addressing statutory sick pay in the care sector, if it isn't already addressed, the permanent part of terms and conditions, then addressing this early in a future pandemic would be important, because you're allowing people to make the right choice without having to factor in their own personal circumstances in a way that I think it's credible did take place in this pandemic. So the earlier and the more certainty, the better. And you could simply have a UK scheme that ensures that this is being delivered, because you could then make sure that it adds up with the tax and benefit system, of course.
So would your evidence then be that the UK scheme would be the way to address the delay?
I think you need the four nations of the UK to have a grown-up conversation about how to do this. And if the inquiry to make a recommendation that this should be addressed, whether it's by an individual UK scheme or by the four governments working together to make sure that the way that the service is organised in each of the four nations is able to do this, then you could have UK-wide consistency, which I think is the objective that should be high on the priority list for a future pandemic. Obviously, it's a matter of the inquiry to decide what recommendations it wishes to make.
Finally, please, on funding. In Wales, the Carers Support Fund was introduced and funding was provided to unpaid carers. Is it your view that that fund achieved its aim and that sufficient funding was provided through that?
It's my understanding, because we had the approach from the relevant carers organisation in Wales, who said that they could administer a fund directly to unpaid carers, because they're the main support group for those carers. They understand who they are and how to administer the fund in a way that is efficient and rapid. And we did make changes to the scheme that we had, where there were, and I think I covered this in my statement, when there was additional demand in different parts of the country, we were able to shift money around. Obviously, understanding from people who were unpaid carers what a future pandemic might look like, not just in PPE, but the practical support that they would need. Money's part of that for some of them, not for all of them. And understanding how you deliver that. I think it's hard to deliver a single scheme that doesn't have elements of discretion in it. But actually, I think that the answer we came up with, and not using the discretionary assistance fund, was the right one to do, because you'd have expected unpaid carers to engage in a fund they may never have heard of and never had interaction with, whereas they were familiar with the carers organisation that we partnered with.
Thank you, and I think this is something you cover in quite a bit of detail in your statement, so I don't have any more questions about that. But can I return, please, to May 2020, and I'm going to return to developments in testing. Can we have on screen, please, INQ 303025882_0016? This is an entry you made in your notebook, and we can't see the date on this page, but it's the 5th of May 2020. And from the initials we can see, perhaps if we can zoom out just to see a little bit more of the page. We can see the initials JF, RS and MH. Thank you. And so can we deduce that this was a Four Nations Health Ministers meeting on the basis of those initials?
Correct. RS is Robin Swan, MH is Matt Hancock, JF is Jean Freeman.
Thank you. Now, you write next to your initials VG, so I think we can take it to mean that this is something you raised in the meeting. Science on testing in care homes, not seen added evidence, advice to test in every care home, would want that shared if it exists, ideally with CMOs. It then says MH, which I take to be Matt Hancock, CMO England advised him to test across care homes, advice updated within last week. And it then says VG, not shared with CMO Wales, and obvious difference to test whole sector as opposed to test homes with symptomatic or confirmed cases. Firstly, following this meeting, are you aware as to whether the advice Mr Hancock had received was in fact shared with Sir Frank Atherton?
No, my understanding is that there was no additional advice note that was shared between CMOs. Frank Atherton was particularly exercised and unhappy about it. I think it's best to be polite about the level of his unhappiness.
And so would it have been helpful if these advice notes were in existence and might be applicable across the Four Nations for such evidence to be shared as quickly as possible?
Of course, and you see the next note, Robin Swan and Jean Freeman agreed, and an advice that should be shared between chief medical officers who were meeting that evening. But my understanding is there was no advice note that was shared. And I don't think it's the sort of thing that Frank Atherton would have kept secret to himself.
No.
This was a highly pressurised environment, highly contested with lots of attention. And it's frustrating even now looking back, because I remember where I was taking these calls and everything that was happening at the time, and it really would have been helpful for all of us if that advice existed, for it to have been shared with all chief medical officers.
Did Mr Hancock offer any reason as to why such significant evidence wasn't being shared that you can recall, or he didn't know either?
No, he said, my CMOs advised me. And that was it. It wasn't that I got this note and I'll send it to you myself.
I'm grateful that document can come down, thank you. On the 2nd of May 2020, you had issued a statement in Wales in which you noted that at that point, the scientific advice did not support blanket testing. Fast forward then to this meeting on the 5th of May. Did you question the scientific advice you were in receipt of if it appeared the UK government had access to different advice?
Well, that's the whole point, isn't it? It's about going back and saying, I've had this call, this is what's going on. Is there an advice note? And there's a fairly lively and exercised conversation between officials, including the chief medical officer, about saying, no, there is no additional advice that we've received. So, you need to be able to trust each other, to work together and to share information. And this is a really good example where that isn't done. You use a good deal of time, energy and effort from your senior decision makers and advisors in chasing something that doesn't appear to exist or isn't being shared. And so you're still reliant on, well, here is the evidence and advice that we have. And I don't think a a brief disclosure in a four-nation health minister's call is a sound basis to upend the advice that you're working on and the evidence you have. I don't understand why, if that advice existed, why it wasn't shared at the time, why it wasn't shared between CMOs. But again, it's another pebble in the pond that has a real practical impact in terms of public confidence around what is being done at the time.
Can I please touch again on some evidence that you gave in Module 7, again with a further focus on the issues being explored in this module? And you were asked in Module 7 about the decision to extend asymptomatic testing to all care homes, which was announced on the 16th of May 2020, and that was an update on a former announcement that had been made in May. And you said, I know somebody said we should have been testing asymptomatically at a much earlier point, but at that point, the advice and the evidence wasn't there to test asymptomatically. If we had had that evidence, we would have had a very practical challenge of how to prioritise the tests. So even if we'd had that advice at a much earlier stage, we would still have had to prioritise about who we're testing and why. And you referenced in response to some questions a statement made by Mr Drakeford in the Senate chamber, and you said the nuance or cut and thrust of the debating chamber doesn't always translate well into having a more forensic examination of it. Mr Drakeford, the First Minister at the time, was setting out that the advice doesn't say that we should do this. And so can I please just clarify, do you accept that prior to the 6th of May 2020, the Welsh Government had received at least some advice that there was value in asymptomatic testing for care homes? And as one of those examples, there was a 1st of May ministerial advice, and you deal with that in your statement at 113 to 114.
Yes, so I'm setting out that we've had advice in that MA that sets out the range of certainty and uncertainty that exists around asymptomatic testing. We've previously moved on treating an individual case as an outbreak in a care home, and so you go and try and deal with all residents at that time and staff. So we had a fairly significant amount of coverage for care homes affected, and that then means that you are testing asymptomatic residents where there has been a positive case in a care home. My point around the point in the debating chamber is that there are times you respond when actually, if you were reflecting and providing a written response, you probably wouldn't use all the same words that are used in the chamber. You know, people do misspeak from time to time. The advice that I'd received has been disclosed to the inquiry, and that's the advice that I was dealing with and making decisions from.
Thank you. Can you please confirm then, was the reason that asymptomatic testing for all care homes not introduced prior to 16th of May because the evidence and advice received didn't support asymptomatic testing generally, or was it because at that stage the advice in light of capacity meant that that shouldn't be prioritised at that stage?
No, I think it's that at that point in time the evidence doesn't support general asymptomatic testing. We've moved on testing residents where there is a COVID case in a care home, but we're not testing everyone where there is no COVID case in a care home from staff or residents. So that's the advice on whether this is the right thing to do, and if you like, scientific and public health terms. Actually, though, I'm trying to recognise in my evidence to the inquiry that if that were the advice at that time, it would require a significant increase in tests. I think the advice note you're referring to talks about 25,000 tests being needed to do so, and the scale-up of that kind in the programme isn't there. And if we announce that we're going to do it, we should be able to deliver it. And if we'd announced we were going to do that on the next day, then we wouldn't have been able to do it on the next day. We needed to scale up our ability to get tests to people and to get them back. So, you know, when England then made other announcements, I think the announcement said they're going to do everything. In fact, they'd agreed a prioritised rollout of testing as well.
So I
So
think
that's
then
that's where which I made choices.
this then is the distinction, because you were being advised that you would need 25,000 more tests, so you would need a lot more capacity. But the advice note on the 1st of May, and it made reference to the Easter 6 study in Public Health England. Do you not agree that that advice note made it plain that there was value, but you would need 25,000 more tests to do it? That's the distinction I'm wondering about.
Yeah, no, from earlier in the pandemic, where the advice is much clearer, look, this isn't really a high-value use of your tests. The advice on asymptomatic transmission is shifting, and through April it shifts quite a lot, actually. And so there's a recognition that there would be some value in asymptomatic testing at that point. It's part of the reason why we'd moved on, where there were COVID cases in care homes, to then test the rest of the residents as well, because of that recognition. And it is still then, though, the advice is still, and it's set out in the advice note, the public health and scientific advice at that point doesn't support testing every care home on a regular asymptomatic basis. It doesn't mean there's no value in doing it, but it doesn't support taking that choice. But if you wanted to do that, then you would need significantly more tests to do it.
And in Module 7, on that section of your evidence, you ended it by saying, with the knowledge we have now, we would make different choices. And I think it's important to acknowledge that. So I appreciate these are views with hindsight, but what choices, even with hindsight, may have been different so that we can learn from them for a future response?
So with hindsight, both on hospital discharge, with hindsight, I think it's the point that we made earlier about testing there. There's then the point about whether you have, when and how you introduce surveillance testing in care homes. That's asymptomatic testing with or without a case being available, and also then stratifying where higher risk homes are. And most of the evidence suggests that larger care homes with larger movements of people in and out of them, which is inevitable, are a higher risk. And so if you had to stratify where to start that testing, you'd start with your larger homes and homes that have positive cases within them. So how you would prioritise that would be, regardless of your resource, I think it's fair to say that you would bump up the list the opportunity to have some form of surveillance testing within closed settings, which care homes are an obvious one.
Can I briefly then touch upon testing capacity? And it's right that you challenged underuse of testing capacity a number of times with those advising you. And you go through this in some detail in your statement. And you sent an email on the 16th of April, and you noted my concern that I was the public face for the COVID-19 testing strategy and responsible for explaining matters to the public. And we touched on this email earlier. You said at this point, I had not been clearly told why we had commitments that we could not meet. And I did not have a sustainable position to offer on increasing capacity and usage, apart from repeating my very real frustration that we were not maximising use of capacity that we had. Now, in your Module 7 statement, you explain when you challenged this, you were told by officials that there were 3 main reasons why maximum capacity could not be used at this time. And to paraphrase, you were told, firstly, we could not plan to use it all as some flexibility was needed. Secondly, we were not able to run and maintain the equipment at full tilt and confirm how long it would reliably run. Thirdly was, of course, laboratory capacity. And if we can please have on screen INQ30s 530780. And I'm close to finishing this topic with you, Mr. Gathing. Just a couple more questions, please. At page 3, now the daily figure of tests that could be undertaken was 2,100, and we can see that on this date, 4th of May, only 892 tests were used. And then scrolling up on the 5th of May, we can see that 743 tests were used. And again, this was dealt with briefly in Module 7, and you said you continued to challenge it. Specifically in respect of what this meant for the adult social care sector, do you feel that you sufficiently challenged why some of these underused tests could not be redirected to the care sector that so desperately needed it?
I don't think that my challenge and questioning in writing and in conversation with officials could be anything less than pointed and robust. But the challenge always is about making sure that as a minister you're properly equipped with information about what's happening and then able to challenge and redirect where required. So the explanations provided to me were rational around the number of tests, the number of purposes, but there wasn't then an explanation about you need to have this number or proportion of tests available to undertake these other functions within the health service. And here's the assessment on the amount of reasonable running capacity. Because the problem is that in my frustration, I explained it was, if that number of 2,100 isn't real, then is it? Because actually, if that's running at full tilt, well, actually, what is the reasonable regular run rate that you could actually have? And we'd be better off saying that rather than the theoretical number that I'm then advised, if we carried on doing that, would make our system fall over. So it's not helpful, I found, to have a number that isn't achievable and then a significant underutilisation of that maximum number without there being an explanation as to why. And actually, some of this is difficult to go out and explain. It says this, but there's a reason why we're not doing that. But at least I'm equipped to make choices about how to explain that to the public. The bigger issue is actually our inability to scale up the testing programme.
And is it your evidence then at this point more tests could and should have been allocated to the care sector, or is your evidence it wasn't possible at this time?
Well, at this time, I wasn't aware that we had extra capacity to allocate anywhere else beyond our priorities. But I still had I forget the date of the tests you showed me, forgive me, Council, but it still goes back into the evidence you had at the time about where and how to deploy your tests regards how many you have them. There, it's May. So by this point...
4th and 5th of May.
Yeah, by this point, we'd had, I think, the ability to use the test, not just in the social care sector, but if we'd had more tests, we probably would have used more tests, I think. But that's also why I'm concerned that the figure is 740, and this time, just over a third of our available testing capacity is being used. I need to know, of that nearly 2/3, do we need to maintain a third of it for other NHS uses? Do we need to maintain half of it? I then have an understanding, or would have an understanding, of how much capacity we could reasonably use on a regular basis in COVID testing, and where and how that could be prioritised. That may not be used fully on every individual day, but I'd have a better idea about how those tests could be used. And that's the point I was trying to make in the conversations I was having, as well as in the emails I was sending, because I need to go out and explain the position, which is contested because we had a testing plan that envisaged us being able to significantly increase our testing capacity that we've not been able to meet. And the Roche element of that was only one element of it. As we then suddenly came out that actually there were things we couldn't say in public, but our equipment that had been held up in different parts of the world as well, that when it arrived did allow us to increase the Public Health Wales laboratory testing capacity that we had independent of Lighthouse Labs.
Thank you, Mr Gething. My lady, I wonder if now is a good time to take a short break.
Certainly, Ms Paisley. I shall return at 25 to 12.
Thank you.
Thank you.
My lady, you are now there, just waiting on Mr Gething.
I'm definitely here.
I'm grateful I can see you now, Mr Gething, thank you. Just two more short questions on testing, please. On the 23rd of November 2020, you agreed that domiciliary care workers should be included in the asymptomatic testing programme for frontline health workers. Do you think that they should have been introduced in that programme earlier, please?
We literally just introduced the asymptomatic testing programme for health workers, and that was on the basis of having lateral flow devices available. So we trialled those. If it's possible, we could have introduced it a day or two earlier. I wouldn't demur from that, but it was about the same time frame, so there wasn't a giant time lag compared to health workers.
When the programme of routine asymptomatic testing was put in place, how were you provided assurances in regards to both residential care and domiciliary care that that testing was in fact taking place?
So we did have problems. So the asymptomatic programs that were introduced, so the regular testing at care homes, we initially had weekly testing at care homes, then we eventually moved to 2 weekly, and then actually COVID rates started to rise, so that changed. It was delivered through Lighthouse Labs and the portal of delivery. Now, we did have challenges on the delivery of that, and I think I'll cover my evidence in September at some point. Myself and Jean Freeman wrote to Matt Hancock, and I think it's common ground that there were problems with Lighthouse Labs at some point. They couldn't cope with the volume of tests, and that actually some of the tests had to be redone because the swabs weren't. You couldn't use them to test because the delay from taking the swab to actually testing them was too great. So I think I covered this in my statement as well, and in previous evidence about needing to maintain confidence. We managed to flex some of our resource available from the increased availability of Public Health Wales lab tests at that time as well.
Thank you. 3 shorter topics, please. The first of those is vaccination as a condition of deployment. Now, the Welsh Government, in contrast to the UK Government, did not impose vaccination as a condition of deployment in the care sector. Can you please briefly explain the main reason the Welsh Government took that decision and whether you think it was the right decision?
I think it was the right decision because our vaccination programme had been successful in reaching a much higher number, well above the minimum levels of percentage vaccination that SAGE had recommended was required. So we were comfortably above both of the markers that SAGE had set. So it wasn't a factor for us to consider. If vaccination as a condition of deployment had been introduced, then we potentially could have lost some of our staff as well. So England had a different challenge. We were in a different position because of the relative success and speed of our own vaccination programme.
The next topic, please, is DNA CPR decisions. Was it ever the intention of the Welsh Government that any of its decisions or policies should lead to the implementation of blanket DNA CPR decisions?
No, that was never our intention, and in fact that was clarified on more than one occasion, both when an incident did arise around a general practice in Bridgend that I've covered in my previous evidence, also from the ethics group, and indeed, I think 2 pieces of correspondence that went out from the Chief Medical Officer and the Chief Nurse reiterating that they had to be individual and informed discussions and decisions, and that age, disability or other factors were not to be used to justify a blanket imposition of DNA CPRs, which did not happen in Wales as far as I'm aware, but there was concern about it.
Now, the inquiries Every Story Matters received evidence, and a care home worker in Wales says our local doctor put a blanket DNA CPR on all his patients to stop them taking up beds in the hospital, which families contested. So were those matters ever brought to your attention that there was some evidence it was taking place?
So we had one incident that I cover in my evidence. I don't know if the Every Story Matters covers the same issue, but it sounds similar. And when that was brought to my attention, we acted quickly. My officials got in touch with the practice. They reversed the position they'd taken, and that led to a broader system-wide reminder of the fact that DNA CPRs should not be used on a blanket basis. Beyond that one incident, no other incidents were brought to my attention, but because of the concern that existed, as I said, we did issue a further system-wide reminder on the appropriate and inappropriate use of DNA CPRs.
And the third of my briefer topics, please, is the regulatory inspection regime. And a number of core participants, including in their corporate statement, the COVID Bereaved Families for Justice Cymru, they've raised concerns about the suspension and general reduction of regulatory inspections over the course of the pandemic. And their concern is that without regulatory oversight, it's difficult to know whether their loved ones were provided with proper care. How were you assured about the care being provided in Wales in the absence of inspections?
So there was a remote interface between care inspector at Wales and care homes. I think Gillian Baranski has covered this in her evidence. It's also important to reflect, though, that reducing the number of visits to care homes was an important factor in trying to minimise the risks of COVID getting into care homes in the first place. I think it would have been pretty unusual to have a couple of inspectors turn up in the middle of April saying they wanted to undertake a normal inspection for a home that was undertaking tasks that were anything but normal. But it's one of those uncomfortable realities of managing the risk means you take decisions you wouldn't normally take in normal times. I think it was the right thing to do, but I recognise that does not come with downsides for people seeking assurance. But the remote contact was part of what we were looking at. And of course, care homes are regularly in contact with us and other stakeholders because of the nature of the pandemic and the guidance. There was a regular stream of contact. It wasn't as if care homes were left to their own devices to do what they wanted when they wanted.
Can I then please move on to personal protective equipment for the care sector? Now, in Module 5, Andrew Slade told the inquiry, and I think we've already said as a government that in a future pandemic, we would immediately move to involving provision for care settings into the work of the Shared Services Partnership. Is that something you agree with and support as well?
Yeah, I think I've said in my own evidence that shared services was a success. And if you had the same situation where supply lines collapsed, then actually moving to a central purchasing service, which is shared services at present, would be a sensible thing to do. And it was overall a success story, and that's also the view of Audit Wales as well.
Can I please ask about some of the specifics? So on the 19th of March 2020, you issued the written statement to announce that the NHS Wales Shared Services Partnership's remit would be extended to secure and supply PPE to social care settings in Wales. Now, the announcement also explained that if PPE could not be accessed while the partnership prepared itself to distribute stock to local authorities, arrangements had been made that care providers could approach local health boards for urgent assistance. What were the practical preparations that had to be made?
Well, every care home has a relationship with its local NHS. So it's not as if there's an entirely unknown relationship that exists. The practical circumstances were, having given instructions for the pandemic stocks to be released, we then need to replenish them and resupply them. And it's about giving confidence to people, because some care homes, having their own established supplies that had collapsed, were genuinely concerned. They talked to colleague care home providers, they talked to the local authority, and they talked to the local health service as well. So the statement was reiterating that if the health board has supply, care homes should approach their health board, and that would they could do that through their general practitioner, through their health board, where they will all have contacts with their health board, seeking assurance around the supply of items, and that obviously depends on what the items are then as well.
Can we please have on screen INQ 30's 349300, page 4, which is an email you sent to various officials on the 3rd of April 2020, and this had followed a meeting with council leaders, and you explain in that email, I will want an update on how our current stocks are being used and how much we have left as soon as we have anything useful about the actual demand and need across health and social care. Was there then limited information reaching you about stock levels and how much was needed across the sector?
Yeah, so I wanted to have and I did then get a regular understanding of the amount of stock, but the problem is having a figure of X 100,000 or X million items isn't particularly helpful, because you need to understand the burn rate, the use rate of those items. And we did then eventually get more granular detail on the number of days of supply we had left for each of the items. And I'm sure that we've disclosed in quite an example of how that was provided. It's also about the level of demand, and that's really important, because demand and need across the sector will differ in different places. Some providers will have more stocks available to them. Not everyone's supply line had collapsed by this point, but it is about understanding where that's a challenge, how do you then meet it? And, every sector outside the NHS is always a bit concerned that is the NHS being prioritised over and above us, and are we really being listened to? And council leaders, as you'd expect, were raising that issue. I know one of them's mentioned in this email. So it was important to not just be sensitive to that concern, but to want to get some reassurance about the level of supply we have and how that's being used. That's why we changed from the published information on the amount of supplies we're giving out to be clear about the level of supplies that are going into social care as well.
And going into the possibility of a future pandemic, is that the minister who has responsibility for this having access to that data something that should be available as early as possible?
Yes, it would be helpful. I think Alan Brace gave evidence on this in Module 5. He was really helpful in getting to grips with what was happening within the system and in making sure that we had a proper understanding of the usage rate, the amount of stock that we then had for the use at that time, because our pandemic stocks had been created on the basis there should be 6 months supply. Given previous episodes, I think we went through them in half that time. So we didn't have 6 months space to get this sorted out at all. So understanding not just the amount of stock you have built up, but in the pandemic you're facing, how quickly can you understand the amount of stock you've got, how long that will last, how many days supply have you got, and are you then supplying just the health sector, or are you then having to take on social care supply as well? And also the clarity of not just the information comes to ministers, but I think it's important that you have a way of publishing and making available publicly what you're doing on that as well, because that is one of the things that can help to maintain confidence across the health and social care sector. And I think when that was published, it was welcomed not just by them, but also by trade unions as well.
A few more questions, please, on this email chain. You received advice from Chris Jones, and on page 3, he said the risk to care workers in care homes and other close communities is likely to be less than in hospital settings, since residents are self-isolating and visitors are banned. However, as we've discussed, expedited discharge at this stage was already taking place. So did you accept the advice that the risk to care homes was less than hospitals?
Yeah, because some hospital settings plainly do have a higher risk level to them. If you're dealing with acutely unwell people, then that is a different level of risk to care homes. It does not mean there is no risk in a care home, far from it. That depends on the tasks that are being undertaken as well, but it is about how you stratify and prioritise. Even within the NHS, even within a hospital, there will be different levels of risk depending on the task you're doing. A hospital porter has a level of risk, but actually that won't necessarily be the same as someone who is in theatre or dealing or working in an emergency department with acutely unwell people as well. So it is about trying to understand the risk for the task that someone is undertaking. And this is a general point around what takes place in a hospital setting compared to a residential home. But it doesn't mean that there's no risk, far from it.
The advice also said the risk to care workers in the community who are visiting people who are being shielded or who are in self-isolation is also low, provided they observe guidance on hand washing. However, at paragraph 1 of that response on page 2, it's confirmed that community transmission was occurring across Wales and the UK. So domiciliary care workers may themselves then have been exposed to the virus, and indeed perhaps many of their clients. So do you think you accepted that advice at that stage?
Yeah, this was advice from the Deputy Chief Medical Officer, but it's on the basis that you're able to successfully implement the measures that are set out. Now, if you're going into someone's home and undertaking personal care tasks, your risk shifts, doesn't it? That's natural. But it depends on the tasks you're undertaking and whether you can successfully undertake the tasks that he refers to. Can you socially distance? Do you need to hand wash? Have you got the appropriate PPE? And that is the point around the relative level of risk. And again, this is all tiered depending on the tasks you're undertaking and the job you're doing, rather than care workers are low risk, health workers are high risk. That sort of crude description isn't what this guidance is trying to set out.
In the event of a future pandemic with similar characteristics, is there anything that can be learned surrounding provision of PPE for the care sector when community transmission is known to be occurring?
Yeah, I think some of this comes back to what we know about this pandemic and the changing evidence base about a range of control measures. So if you can undertake social distancing, that is a control measure that protects you and the person you're potentially undertaking tasks for. If you can't do that, then in particular, the changing nature of what we're able to do on face masks and fluid resistant ones would be important as well. The points around ventilation, excuse me, to ensure that if it's possible to be in a well-ventilated setting, that reduces the risks for everyone who's undertaking those tasks as well. So I do think there are areas of learning, both about the understanding of the risk about the task that is being undertaken, whether you can practice some of the control measures, and if you can't, how PPE is used to protect both you as the worker and the person you're undertaking those tasks for, and those other control measures, say, including PPE and otherwise. This would mean, as we got to, that there would be an increase in the demand for PPE itself. So it goes back into, with this type of pandemic, you need to have the certainty about your supply lines and ideally a larger stock than we had at the start of this pandemic as well.
Can I just pick up on something you said, please, which was the importance of ventilation? Do you think during this pandemic, Welsh ministers had enough access to information about the ability of care homes to ventilate, or is that also an area of learning?
I think it's an area of learning because our understanding of ventilation developed through the pandemic. So you consider the conversations we were having in April compared to June 2020, compared to December 2020, there's quite a lot of moving on. I don't know if you recall that on one of the May bank holidays, I think the late May bank holiday, a number of people went out and had a drink, and there were regular reports of social distancing disappearing after the second or third drink. There was lots of concern that would lead to a spike in COVID in another 3 weeks' time. Part of the reason why that didn't happen is that actually when people were drinking outside, then actually you're much more protected than being in an indoor setting as well. So our understanding of the benefit of ventilation shifted significantly through a period of months. Having well-ventilated spaces in care homes, either for visiting pods outside the normal care home or how to facilitate indoor visits, our understanding has shifted significantly. A similar pandemic, we could undertake different measures at a much earlier point that would enable low-risk contact with people, whether that's for care or indeed for visits.
Two more brief questions, please, on PPE. By the 7th of May 2020, which was 7 weeks after your written statement on the 19th of March that we have looked at, 2/3 of the social care sector's PPE needs were being met by the NHS shared services partnership arrangements. Now, you explain that you consider that the availability of PPE to the sector had improved considerably. Now, whilst it may have improved, that did mean that 1/3 of the sector's PPE needs were not being met. And so my question is, can you provide an overview of your understanding as to why that was the position and how that position could be avoided in the future?
I don't agree with the premise of the question. My statement that 2/3 of the PPE needs were being met by shared services shows the amount that was being delivered by shared services. The other third, we didn't receive complaints. There was no PPE available and people were managing without it. It was actually about how they were securing, potentially through alternative means, their own PPE supplies. So we're taking up the slack for the challenge for 2/3 of the sector at this point in time, and it's being done through shared services with no cost to those care homes that require it. But other care homes are still managing to get some PPE for themselves. So that's the point I'm trying to make, rather than 1/3 of care homes are left without PPE. I wouldn't want to leave that impression out there, because that's not what I'm trying to get over in my evidence.
I'm grateful for the distinction, Mr Gething. The inquiry has heard evidence, however, that throughout April there were difficulties, and what I'm seeking to address is getting this programme off the ground. Is there any learning for the future about the original delays? I appreciate what you're saying in respect of May, but throughout April, is there any learning about why there were shortages as it was being established?
So I think that is really about how quickly you're able to significantly increase supply, and not just the global supply, that comes into a country, but actually how you then distribute that as well. So we made use of the joint equipment stores that local authorities had because people were used in a local authority area to accessing information and supplies to and from that and distribution from local authorities. How quickly people actually bought into wanting and needing to have supplies provided by NHS shared services, not just Carmarthenshire that said it would go it alone, then had to come back because it couldn't source those supplies. So I think the learning is how quickly are you able to make a choice that you need to be able to source supply in a different way, and the myriad procurement arrangements are not going to hold up to the pressure that they'll be under. It's then also about where and how do you get that from outside of the UK, and how quickly can you scale up home production of that? Because lots of PPE that is produced in the UK is more expensive than sourcing it internationally. And so the tyranny of numbers and budgets means that you are going to supply that in normal times by procuring it from overseas. If those supply lines are breaking, how quickly can you get up supply here in the UK and for private businesses to repurpose what they're doing? So I think there is learning in that, but it still relies on your understanding of the pandemic you're facing, the stock you have available to you, and how quickly you're able to interact with an international market with a purchaser, a procurer that has a success track record. And then your points earlier about the amount of stock and how that gives confidence within the system and the wider public, I think are relevant too.
Going to change topic again, please, and can I move on to visiting? Now, you explain in your statement at paragraph 207 that the first piece of guidance for the care sector on visiting was communicated on the 23rd of March 2020, which advised that visits to care homes should only take place when absolutely essential and not part of routine visiting. What was the intention behind the phrasing absolutely essential? And do you think that guidance could have explained more clearly the intention behind what that meant?
Yeah, so we're thinking about compassionate visits, and that would include end-of-life care. And I think later guidance clarified that. So if in the first iteration we'd been able to describe what we subsequently did, that could have helped. So I think it's reasonable to accept that description, if it was provided early, would have helped everyone.
Would you agree similarly in respect of end of life? Because the inquiry's heard evidence that was interpreted in some cases to mean the last few hours or the last few days, whereas some providers interpreted that more widely. Do you think it would have been helpful to give a definition or more guidance on interpreting end of life?
I can see that. I think there's a note of caution here in that the level of detail you go into in the guidance can give you certainty up to a point, but you need people to understand and then implement the guidance. The longer and more complex the guidance, the harder it is to successfully and consistently implement. So there is a balance to be struck here. But I think as we go through the pandemic, we are learning more about what helps to meet the needs of providers and the public who are interacting with the sector. But I think it is important to put on record, you've got to strike a balance in that, because otherwise, if you write a telephone directive guidance covering everything, that's not a fair fight for a care home provider to go through that, understand it, and implement it with the speed that was required.
To what extent was the impact upon disabled people and those with dementia, who often relied upon their family members to advocate on their behalf in respect of care, considered particularly in respect of those blanket bans, for example, from the 23rd of March?
It was really difficult because, again, you have this balance of for people and their general sense of well-being, the visits are a part of what helps to maintain that. When you interrupt that, that will impact residents. The alternative challenge is, though, that if you have regular visiting continuing, then you'll see more COVID in more care homes, with all of the consequences that come with that. So, this isn't straightforward, and you're trying to balance and manage all those risks and rights. And at the same time, at this point, the real and reasonable fear is that if you don't put more protection to restrict the number of people going to care homes, then you will see harm go into those care homes that you can't undo.
If the Welsh Government was to approach this situation again now in the future, are any lessons learned from the experience of visiting, and would you do anything different next time?
Yeah, so I think with the benefit of hindsight and the learning we've got, the point I made earlier on ventilation is important and relevant because you could undertake more visiting at an earlier point successfully or with an acceptable level of low risk. I think it's important to recognise that visiting is an activity that comes with risk, but there's a balance of that risk about what happens to the resident without visiting as well. When you have the ability to visit outdoors, that of course is safer, as we now know. So I think there are things that you could do to think about the position we reached on visiting, where outdoor visits, particularly in times of lower prevalence, were to be managed successfully. Even in times of higher prevalence, visiting with social distancing was possible outdoors and in the pods that we helped to procure as well. Where people couldn't move outdoors, the control measures you could undertake including ventilation, to allow visiting to take place. It's much like when we think about visiting an accompaniment for healthcare services, think about people that were pregnant and weren't able to have their birth partner with them. We've recognised before in different modules that we would want to revisit that and in the future do that differently. In care home visiting, I think it's important to recognise that the knowledge we now have, we'd have a different approach to it. The counterfactual, of course, is confidence in what you're doing. Some people were so desperately concerned, and rationally so, with the idea that large numbers of visitors would still come into care homes would be something they'd be unhappy about. But if you're able to point out, we think this pandemic, there are control measures we can undertake, ventilation is one of them, adequate solar PPE is another, and we now have rapid lateral flow type tests that mean that we can help reduce the risk further, then you could have a very different approach to visiting much earlier, and that would definitely benefit residents who I accept had their well-being compromised by the control measures that were introduced at various points in the pandemic.
Can I briefly ask, please, about timeliness of guidance, visiting guidance? Now, on the 5th of June, a letter was written to the sector following the move to stay local on the 1st of June. So that was 5 days later. And you say this prompted a lot of queries regarding the position on care home visits. Looking back, do you think it would have been helpful to consider and produce guidance ahead of those types of larger moves for the rest of the community?
Yeah, I think there's something of the capacity of the government to do everything all at the same time and to work with different stakeholders. And, you know, as we go through, if you think about where we were in May and the amount of headroom we thought we had to make changes, to get all that right and to get the guidance ready, you've got to anticipate that and look at that earlier. If there was a future pandemic, I think we would be anticipating this and there'd be an opportunity to do this sooner. But I think at the time, I don't think it'd be reasonable for me to say that we would have been able to do this much, much earlier. In the future, though, it would be a different consideration because of what we learnt in this pandemic and the ability to apply that in the future.
Regarding responsibility for visiting decisions or the guidance that's produced, Ms Herclots told the inquiry yesterday, I think ultimately it needs to be a clear decision by Welsh Government because it is the body that can coordinate what is happening. It felt to me that they were waiting on advice from Public Health Wales, and therefore it felt like maybe almost by default it was a sort of Public Health Wales decision. So I think in any pandemic in the future, I think, you know, governments need to own those decisions and they need to be clear about where they're taking advice and then the decisions that they're making as a government on that basis. And do you have any comments on what she said, please?
Well, the government does own the decisions we made. And, you know, you have to take advice and guidance from people with expertise, and Public Health Wales are there for that purpose. The challenge then is how you communicate that and how quickly and rapidly and consistently you can communicate that as well. So if the suggestion is that we essentially devolved our responsibility, I don't accept that. We took decisions and we had to explain those decisions as we did on a regular basis. In the future, as I've said in answer to your previous question, I think we'd be able to make some of those choices earlier, to draw in stakeholders, both Public Health Wales, but also stakeholders within the sector as well, to understand, with the pandemic that's in front of you at that point in time, how quickly can you move? And then, of course, we move to a position where local authority level decisions were able to be made on changing visiting as well, because the situation in Gwynedd could be radically different from the situation in Bridgend. And so trying to make a national choice about all of those would actually get in the way of making the right choice. But the incident management team process is important to make sure you've got local public health advice from Public Health Wales and your health board, together with the local authority and the homes, to understand what choice you're making. So it commands support from all the stakeholders who need to be there to make it work. And I know that we had a couple of instances where that didn't happen.
Thank you, Mr. Gathing. I have just two final questions for you, please. Firstly, the Welsh Government produced a care home action plan, which focused on 6 areas: infection prevention and control, personal protective equipment, general and clinical support for care homes, residents' wellbeing, social care workers' wellbeing, and financial sustainability. And the inquiry understands that there were regular updates provided to the Deputy Minister on progress. Do you think that that would be a useful tool for the future, and did you find that beneficial?
I think so. The Care Homes Action Plan was drawn together with learning from the first phase in the pandemic about what had worked and what hadn't worked. And the fact that we had someone with expertise and standing in the sector to do that fairly quickly was also, I think, helpful. And I think it did help with the level of buy-in. If you're looking at a future pandemic with the level of learning we have now, it would be possible to take an early look at what is happening practically within care homes, to understand how the pandemic planning that we as a nation would have at that point is being implemented, how successfully or not, and how to understand and deliver learning. The warning note, I think, to sound is, and I think it's a reasonable one, is that if you're going to do that, you need to have the space and the time to do it. If people are dealing with the emergency in that moment and all of their energy is invested in doing that, to then say we want to have a new action plan delivered on top of that, you've got to make certain there's capacity to do it and the ability to learn, to then see if you need to do something differently as well. And I think the earlier demands from the Older Persons Commissioner were at a time where actually it wasn't the right thing to do, but we did do it over the summer. And like I said, those relatively low prevalence levels gave us the space to do that, to try to be in a better position for the autumn. But that learning is now there. And I hope that both with this inquiry and what we're doing anyway, that learning won't be forgotten and will inform future action.
My final question, please. Other than anything we've already covered in your evidence, are there any particular recommendations you think are important for this inquiry to consider, specific to this module, please?
Right at the end of my statement, I've set out a range of, I think I've invested in 3. And I think one we haven't covered is the consistency of isolation facilities and residential and nursing homes. There's a point there about future reform in the sector, but this would be something that I think would be relevant to every flu season and every outbreak of an infectious condition in normal times, and would also provide, I hope, a greater success rate about the ability to isolate residents in a supportive environment in the future as well. That would require both a review of the sector and also some investment on a consistent basis and how those facilities are maintained as well.
I'm grateful, Mr. Gathing. My lady, I have no further questions, but there are some core participant questions.
Thank you very much, Ms. Paisley. Mr. Gathing, as you know, there will now be some questions from the core participants. I only allot them a certain amount of time, so I'm sure they'll be grateful, and I'll be grateful if you keep your answers as short as you reasonably can. Mr. Stanton.
Thank you, my lady. Good afternoon, Mr. Gathing.
Good afternoon, Prynhawn Da.
As you may know, I ask questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. I have a small number of topics to cover with you. And the first relates to the decision that you took on the 25th of November 2020 to delay the use of the Pfizer vaccine in care homes for the first 4 weeks of delivery. You addressed this issue at paragraphs 302 to 321 of your statement. And at paragraph 304, you acknowledged that the advice of the Joint Committee on Vaccination and Immunisation on the 25th of September 2020 was that the first priority group for vaccination should be older adult residents of care homes. The reason elderly care home residents were the first priority group was because of their extreme vulnerability, and in this respect, scientific studies record the case fatality rate of elderly unvaccinated care home residents as high as 36%. That is approximately 1 in 3 infections proved fatal. And for the inquiry record, this data is taken from the research paper authored by Professor Shallcross and others at INQ 000 544 928, which identified that of 607 residents with confirmed infections, 217 died. Mr. Gething, given these alarming statistics, do you accept that by not following JCVI advice to prioritise care home residents for vaccination, you failed to protect them?
No, I don't accept the formulation of the question. If you look at all the evidence I've provided, and in my statement, not just paragraph 304, but paragraph 305 and 306 as well, setting out the challenges of delivery of the Pfizer vaccine. It was very different with AstraZeneca when it was much more portable, needed ultra-low freezer storage, and actually the ability to successfully deliver that. So this was a point that I discussed with officials delivering the programme. I know Dr. Richardson gave evidence on this in the vaccines module as well. And on paragraph 306, there's the pilot for the rollout, where we looked at a care home in Betsy Cadwallader and the learning from that to understand how that would then be introduced as quickly as possible, because I always understood that vaccination in the absence of a curative treatment was going to be essential for us to get out of the pandemic.
Thank you. Mr. Gething, could we have a look, please, at the statement of Dr. Richardson? You just mentioned her evidence in your answer just now. And can we have up on screen, please, INQ 000 501 330 underscore 0018. Hopefully you have that.
I see that in front of me, yes.
Thank you. Mr. Gething, at the second sentence of paragraph 67, you'll see it reads, on the 25th of August 2020, it was recorded that there was a significant risk of insufficient freezer storage being available to store a vaccine requiring a temperature of minus 70 degrees centigrade. Should such a vaccine receive regulatory approval, the mitigating action was assess current and identify additional sources of appropriate freezer capacity. And if we could separately look at some data provided to Care Inspectorate Wales around the notification of deaths in care homes around this time at INQ 000 198 645 at tab 9. Again, hopefully you have that before you. Ms. Gething, if I could draw your attention to columns D and E and rows 10 through to 16, you'll see there suspected and confirmed COVID deaths are recorded, and we can quite clearly see the tail end of wave 1, and then through July, August, September, numbers remaining relatively low, before starting, sadly, to build again in October through November and December, and then reaching a peak in January. I'd suggest to you, Mr. Gething, that the summer and early autumn of 2020 provided an opportunity to take action in respect of the need for refrigeration and other measures in order to be able to deliver the Pfizer vaccine. would you accept, Mr Gething, that more action ought to have been taken in this period to ensure you're in a position to vaccinate the most vulnerable?
I think when you look at all of Dr. Richardson's evidence, it does go through the fact that the Vaccination Programme Board were looking at how to try to manage the Pfizer vaccine. It wasn't certain this would be the first candidate vaccine. That was never a discussion that I had until much later. There were real challenges, though, that the Vaccine Programme Board had with not just the ultra-low freezer element of it, but actually the ability to move it around and to get it from one care home to another. So there were real practical challenges in how to do that. And when we look at the figures that you've highlighted, this is the reality of the fact that more COVID in circulation, and by this point in November, December, January, with a more transmissible variant as well, that's what these figures are showing. Now, of course, if we'd been able to introduce any successful vaccine earlier, we could have seen an impact in these mortality figures. But we needed to be able to deliver that vaccine safely to all of the people who needed it. And that's what we tried to do.
Thank you, Mr Gething. Vaccinations in Wales commenced on the 8th of December 2020. However, by the end of January, nearly 2 months later, you had only vaccinated 11,000 care home residents, or around 67% of the population. This is confirmed in the Vaccines Weekly Update of the 26th of January 2021, which is at INQ 000 508 504. However, I don't think we'll need to go to this document because you deal with this issue, Mr Gething, in paragraph 310 of your statement. At page 2 of this update, it's also confirmed that some 290,000 people had been vaccinated in Wales by this time, which means that care home residents had been leapfrogged by several other priority groups. And in this regard, Mr Gething, please can I refer you to evidence which I'll ask is brought up on screen of Professor Lim that was given to the inquiry during the Module 4 hearings. This is at PHT 60143_0023. And when you have that, Mr Gething, the section I'd like to refer you to is at page 89 of the transcript from line 17, and it reads, the number needed to vaccinate to prevent one person dying in cohort 1 was calculated by the Institute of Actuaries as 20. In other words, if we vaccinated 20 people who are resident in an old age care home, we would protect one life. The same number needed to protect one person from dying in a 65-year-old cohort was 1,000, and the number needed to vaccinate to save one life in the 50-plus cohort is 8,000. Mr Gething, having regard to this information, do you accept that had care home residents been vaccinated promptly in accordance with JCVI advice, many more lives could have been saved?
Our vaccination programme acted in accordance with JCVI advice. If there's a suggestion that we ignored that, that is one that I do not agree with, and I don't think the evidence bears that out. You put to me paragraph 310 of my statement, and in paragraph 310 of my statement I explain why we hadn't been able to vaccinate 70% of people over 80 and in care homes. There had been a range of factors within that were beyond our control, but if you can't vaccinate residents in care homes, it doesn't mean you should not vaccinate other people in those top 2 risk groups, because the JCVI advice was to vaccinate people in the top 2 risk groups. And that's how the cohorts were working, and that's what we did. So, and when you look at what we did in our vaccination programme, we were successful in getting to large numbers of people really quite quickly, and the scale and the pace of the vaccination programme significantly increased through January and February as the lessons learned from practical delivery were applied in practice.
Thank you, Mr Gething. Just in respect of an answer you gave there, that you were following JCVI advice, Wales was the only country to delay provision of the vaccine, and indeed other UK countries had noted that. Westminster government noting in a meeting on the 12th of January that the Welsh government was different to other nations, and they had prioritised NHS staff. So I'm not sure I accept what you say in respect of following JCVI advice.
We didn't delay the delivery of the vaccine, and I certainly wouldn't take as gospel a statement by the UK government. You'll recall this was a highly contested political environment at the time. I undertook a huge amount of work practically with the vaccine delivery group. This is a part of the pandemic I recall really vividly. The amount of time and different days, using my son's bedroom to run meetings, to understand where we were, to understand the pace we could inject. And at the same time, there was quite difficult and sharply political criticism within Wales and outside. And I do reject the suggestion, which I find offensive, that we're sitting on the vaccine and failing to meet our obligations and work in accordance with JCVI advice. And if you look at what we did in the vaccination programme in Wales, we had an efficient and fast rollout of the vaccine, and we covered our most vulnerable groups at real pace that led to us being able to make choices to leave the extraordinary lockdown we experienced through winter 2020 to 21.
Thank you, Mr. Gething. I'll take you to another decision around this time, please, that I suggest similarly failed to protect and prioritise care home residents. Namely, the decision on the 15th of December to allow what has been described as low positive testing patients to be discharged from hospital to care homes. Your statement announcing this decision is at INQ 000 227 285, which we don't need to bring up. The timing of this decision is at a point when you had suspended Pfizer vaccines in care homes, and at a time, as we've just seen, when deaths were rising within care homes. Can I ask you, what impact did this change in policy have on infections and deaths in care homes in Wales?
The change was made based on the advice that low positivity readings the low positivity readings that we had changed the advice on were ones where people were no longer infectious. That's covered in my statement. It's covered in the statements I issued at the time. It's also referred to in Professor Corr's evidence that he's given to this inquiry as well. The suggestion that that has somehow led to an increase in infections in care homes is not one that is borne out by the evidence.
Can I then, Mr. Gething, please take you and have up on screen to the advice of the Technical Advisory Group of the 11th of December 2020, upon which your decision was based. That's at INQ 000 350 671 _0002. And at the top of that page, when you have it, you'll see the statement, there remains uncertainty around the period of infectivity for individuals infected with SARS-CoV-2. This document does go on to indicate that there was high confidence in the decision around low-level positive testing. However, nevertheless, there remained a risk. My question to you is, given the extreme vulnerability of care home residents, the way that the virus, once it was seeded within care homes, rapidly spread within it, the fact that care homes were ill-equipped to cope with infection breakouts, and at a time when vaccinations had been suspended in care homes, why were you willing to take this risk, even a small risk?
This comes back to where and how you judge risk and harm. If you have someone who is low positive and you keep them in a hospital setting, then that person is at risk of greater harm. And the evidence that we point to here does not justify keeping that person in that state. There is risk from care home staff going into a care home every day. but you understand those people have to go into the care home to undertake their work. And this is a decision that is based on the evidence at the time, and I have not seen any evidence that this decision led to infections in care homes. And this is the point about learning what to do in a future pandemic. And if you want to take zero risk choices, then those choices will in themselves cause harm. And this is both the harm for the person who's in the wrong place, but also the harm of the person who can't get into a hospital when it should be the right place for their care and treatment to take place. And I have responsibility for the whole country, not one section of it. So this is an evidence-based choice. And I think it's important that decision makers in the future make choices based on the evidence.
Thank you, Mr. Gething. My final question relates to paragraph 96 of your witness statement, which I'd be grateful if we could have up on screen, please. That's at INQ 000-587-254_0023. And you'll see that, Mr. Gething, first line of that paragraph. As ever, the most vulnerable people in Wales were at the heart of the decision-making process. Mr. Gething, having regard to the risks taken with the safety of elderly people in care homes just described, can you legitimately make this claim?
Yes. If you look at the choices we made whole society choices to protect the most vulnerable people. And we knew that COVID as a condition was something that affected people with particular additional healthcare conditions, and age was a significant factor. And that's why the JCVI advice on vaccination places a high regard on the age of individuals. So in an NHS hospital, on any day, the people in a hospital bed are overwhelmingly older people. Those people are vulnerable when hospital is no longer the right place for them. Those people living in their own homes outside of a hospital are more vulnerable if they get COVID. If those people need to move from their home into a hospital, you need to have a hospital bed for them. You need to do this in a way that recognises the risks in the community, in an ambulance, in a hospital, in a care home, and those people are then returning to their own home as well, and all of the staff who are engaged in that as well. And that is why we made whole society choices on what to do to manage those risks, to understand the balance of harm in every choice that you have to make. And that is the way that I approach making choices. And those are still the considerations I have in approaching this inquiry about how you understand how not just the choices we made, but the choices you could make in the future with a similar or even a different pandemic, and the choices that inevitably any decision maker will have to face.
Thank you, Mr. Gething. Thank you, my lady.
Thank you very much, Mr. Stanton. Miss Morris.
Thank you, my lady. Mr. Gething, can you see and hear me okay?
I can indeed.
Thank you. Good afternoon. My question is about visiting restrictions, please. And the inquiry has heard evidence, and has evidence before it from Helena Herclot, the Older People's Commissioner for Wales, that in her view, the initial guidance did not take account of the harm to health and well-being from older people of being isolated. And in fact, you said in your statement that as of August 2020, you were aware of the growing concern expressed by the Older People's Commissioner and others about the negative impact that the restrictions on visiting and physical separation from loved ones was continuing to have. Is it fair to say that there was a lack of understanding about care homes and the rights of older people in visiting guidance, particularly in the initial stages?
No, I don't think so, because in the initial stages, you recall in March, we're just going into lockdown, and we have a transmissible condition that is more likely to affect older people in particular, and we don't understand everything about how it is transmitted, but we do know that there are real risks, and we're facing up to a reasonable worst-case scenario where over 500,000 people could die. So the choices made at that point are rational. You then understand the more direct impact of those choices as you get deeper into the pandemic. And of course, the Older Persons Commission was also saying at various points in time that she wanted more protection around care homes. Well, visiting is part of the risk. It's also part of how you maintain a general sense of well-being and the health of people in those care homes. It's about striking the balance that's important. And I said in my statement that we would need to consider how that balance is struck, and in earlier evidence about how that balance could have been struck at an earlier point to enable visiting with a much lower level of risk than we understood in March 2020.
So in hindsight, ought the focus to have been on enabling safe visiting rather than a blanket ban?
Well, in hindsight, I think we could have moved faster on enabling safer visiting, low-risk visiting. That's the point that I made in answer to counsel to the inquiry. But in March 2020, when we go into lockdown and when the restrictions come in place, we're not aware that we can enable safe, low-risk visiting generally, but there is still a provision for compassionate visiting. We've gone through the issues around exceptional circumstance visiting and how the guidance could have been written in a way that enabled people to understand more clearly what that was. So I don't seek to change the evidence I've given in that regard, but I don't think it's fair to say that in March 2020, just after going into lockdown, we could have enabled safe visiting at that point in time because we just didn't have the knowledge base to do so. A future pandemic, we have different considerations to take into account about how to have a lower level of risk to enable more visiting to take place, whether outdoors or potentially indoors, as I've described in earlier evidence.
Thank you very much. Thank you, my lady.
Thank you, Ms Morris. Ms Peacock.
Thank you, my lady. Good afternoon, Mr Gething. I ask questions on behalf of the Trades Union Congress. My questions relate to the concerns raised about PPE provision in the social care sector. And if we could bring up your witness statement on screen, it's at paragraph 175. Hopefully you have that in front of you.
I do.
You describe concerns about PPE were also raised by trade unions representing the care sector. On 30th of March, I received a letter from the GMB union. And then you go on to say several lines below, my initial response to the letter was that some of the demands set out were unachievable. On PPE, I commented that it is an odd position to be put in when the GMB are demanding that we equip the private sector staff with PPE that I assume the employer is legally responsible for from the public purse. In effect, the letter was seeking priority over publicly funded provision we were more directly responsible for us to provide the sector over. And if we could just bring that letter up on screen, it's at 180891 at page 1. Hopefully you now have that on screen. The letter states on the first line of the first page, GMB Union represents members right across social care, both public and private employees. We understand that these are exceptional times and advice and guidance is changing daily. And then if we could turn over to the second page, the second paragraph regarding PPE and social care states, our members in the independent private sector feel let down at a time when they have put themselves on the front line. GMB has been contacted by managers in despair at feeling they're putting their staff in harm's way and are unable to do anything to protect them, as it seems that the PPE you've requested be released isn't getting through to those that need it. And then in the final sentence of that paragraph, it states, the health and safety of key workers must remain a priority. Can you please advise me of what you are doing to address this crisis within a crisis? I just want to clarify the request made in that letter from GMB. Can you agree that there's no request in that letter for one set of workers to be given priority for PPE over another set of workers? In fact, the letter simply raises a serious issue around access to PPE in the private sector for care workers and asks for an explanation from Welsh Government of their approach to the issue.
No, look, I think the letter points out that their particular concern is about members in the independent private sector. And of course, it calls on workers remaining a priority for Welsh Government and all employers. Now, this goes back to who we are and aren't legally responsible for, but also the fact that the government is the last resort. Well, when the government can't resolve it, you call in the military, which we did, of course, during the pandemic. So it's about a demand that PPE is released to the independent sector, but that then means my concern is, do we have enough to deal with all those people we are responsible for? It's about trying to understand what we can do and how quickly we can do it, and the challenge of maintaining confidence and making sure that people do get supplies of PPE that they need. And as I've said in previous ones, I think we did this rapidly through shared services and fairly successfully, but that doesn't mean that there were uncomfortable circumstances for staff at the time, which I've recognised both in my evidence inquiry and indeed at the time. I think I said that PPE was a bigger concern for me at various points in time than testing, because of my concern that we wouldn't have adequate PPE for frontline workers to use.
Thank you for your explanation about the concerns which you had arising from the letter, but I just want to be very clear that the request made by the GMB is not that priority is given to one particular set of workers. In fact, the GMB explicitly mentions that they represent both public and private employees, and the request is that the health and safety of all key workers must remain a priority, rather than suggesting one are given priority over the other. Is that right?
It then goes on to give examples only from the independent sector as well. We're not legally responsible for the independent sector and the provision of PPE. This is about how the resources of the government are used. And if we need PPE that is available for people we're directly responsible for, then we've got responsibility to do that. That's the point I'm trying to make in my email correspondence. I should point out I'm a member of the GMB. I know it's in my statement, but
I'm grateful. I just wanted to be very clear about what the request from the GMB was in that letter. And you acknowledge in your statement at that same paragraph we've touched upon that supply chains for PPE collapsed. Do you agree that in those circumstances, in a pandemic where private employers are seeking to but are unable to provide their employers with PPE, it's reasonable to ask the government to step in and address supply?
Which is what we did.
I'm grateful. Thank you, my lady.
Thank you very much indeed, Ms Peacock. It's now Ms Jones.
Thank you, my lady. Mr Gething, I ask questions on behalf of John's Campaign, the Patients Association and Care Rights UK. You said in your evidence this morning that the voice of unpaid carers was significant throughout the pandemic, but the experience of the organisations I represent was that there was little support provided for unpaid carers, including the millions of people who newly found themselves providing unpaid care to loved ones during the pandemic, and who were simply expected to step up and fill the gaps created when healthcare, care and respite services were suspended. My question is this: to what extent did you and the Welsh Government consider the impact on unpaid carers of decisions like expedited hospital discharges at the same time that other services were being suspended? And what, if anything, did you and the Welsh Government do to reduce the strain being put on unpaid carers?
This developed through the pandemic, and I think I've gone through this several times in evidence, in writing and in different modules as well as today. The decision on the 13th is about how you manage the risk that the whole country is facing and the harm that the whole country is facing. And if you're not prepared to act, then you're essentially accepting that your health and care system is going to break down with potentially catastrophic harm to staff and to the public. And in understanding what you can do to support unpaid carers, we had a range of things that we did, from food delivery to the work that we did with the Carers Trust. And that came on the back of not just having a regular voice in press conferences, but actually engagement with carers organisations about how to try to provide practical support for them. And you're right, there were people who had new responsibilities they hadn't had before. But those are driven by, I think, unavoidable choices to the way the health and social care system needed to change rapidly to avoid being overrun. In a future pandemic, I think we'd be better prepared for what that means for different groups of people. And I've said myself, I had to take on new responsibilities, relatively low level, but I had to do those and my job because there wasn't alternative provision in place, because the advice we were giving people that meant they had to stay in their own home. So that's a pretty significant undertaking for everyone, and it comes with a level of discomfort. And I do hope that when the inquiry comes to reach its conclusions, there can be something about understanding not just what happened with unpaid carers, but are there practical ways that we could provide support earlier? And I think where we reached with the scheme we provided through a carers organisation, in hindsight, and if you're looking at a future pandemic, we could have been able to do something like that earlier to provide more practical support for the role that unpaid carers are undertaking.
Thank you, Mr. Gething. My next topic is about the problems with data about the care sector. You recognise at paragraph 79 of your witness statement for this module that data across the care sector was fragmented, and that's supported by evidence that the inquiry has received from other witnesses in this module as well. Do you agree that the response to the pandemic in adult social care was hampered by a lack of reliable data about the adult social care sector?
Yes, if we'd had more reliable data, then it would have allowed us to have a better overview of the sector, potentially where and how we get information, but also resources to parts of that sector as well. I don't think there's any dispute with that.
Thank you. And in terms of the kind of data that might be necessary, the organisations I represent are concerned that there are particular holes around lack of data about bed capacity, number and identity of staff and the type of services that are provided at different care settings, but also that there's a lack of qualitative data reflecting the views of people who draw on care and, for example, the impact on them of things like the COVID-19 visitor restrictions. From your experience during the pandemic, do you agree that these are areas where better data collection is necessary? And do you have any views on how such data could be collected in order to inform decisions that were made?
So the understanding of bed numbers and settings, having a clearer handle on that would obviously be useful. You understand more about what you're able to do in terms of flow through the whole health and social care system. The recommendation that I've made, the Council Inquiry allowed me to highlight around individual isolation for infection prevention and control, that's quite important as well. When you're then talking about the qualitative experience, I think that should be a regular feature of the way the health and social care system runs in terms of the access to whether it's patient care or the care that takes place in a social care setting and the value of it. And when that's withdrawn, or is restricted, the impact that has, because that then allows you to understand more clearly the balance of harms that you've got to try and balance. I still think it was inevitable there was going to be a restriction on visiting, because otherwise you'd have imported much greater risk of harm into all those care settings. So it's about how do you enable some form of contact to be made. So we eventually, you recall this in my statement, that we provided a range of devices to homes that didn't have them to allow remote contact to take place, which isn't the same as in-person contact. And also the evidence I've given about whether you can take lessons from this pandemic to allow visiting to take place in a much lower risk environment in the future. And I'm sure that not just my evidence or others, the inquiry will consider that when making its recommendations.
Thank you, Mr. Gething. Can I just follow up on whether you have any views on how that data could be collected, or which bodies are the organisations that you think should be collecting it for future?
Well, it's different in Wales and England because our systems are different, the same with Scotland. I think the information inspectorate has is important, but it's also, I think, important for local authorities with statutory responsibility to have access to predictable and reliable data they can share with the Welsh Government as well. On those homes. Then the qualitative data, I think when you're dealing with a pandemic that has an infectious condition, it's really hard to have that face-to-face contact to get that qualitative data as well. So you're going to be reliant on how your normal systems, where it's face-to-face it normally does it, can stand up to an interruption of that. So I think some remote conversations about that, both with staff and with residents, would help in doing that and making sure that your snapshot is a reasonable one. I think there's a role for local authorities in all of this because the Commissioner isn't going to be able to provide that comprehensive view.
Thank you, Mr. Gething. Those are all of my questions.
Thank you, Ms. Jones. Ms. Beattie.
My lady, I do not have any questions, thank you.
Oh, right. Sorry if I misread it. Okay, well, thank you very much anyway. Mr. Gething, that completes the questions that we have for you for this module. I'm afraid I cannot give you any guarantees. We won't be calling on you again. I know we've called on you, is it 5 times already? But like Mr. Hancock, you played such a role during the pandemic. I'm afraid there's no alternative. But I promise you we'll limit any burden on you that we can. Thank you very much indeed for your help.
Thank you.
Very well, we shall break now and I shall return at 10 to 2.